Good morning. My name is Dr. Kevin Ford, and I'm a member of Omega Psi Phi Fraternity Incorporated Gamma Pi chapter, and I'm the chairman of the Health Initiative Committee. And welcome to our monthly webinar that we do on health topics. This month is Colorectal Cancer Awareness Month, and we're pleased to have two guest speakers today. The first speaker will be Brother Dr. Thomas Abernathy Jr. Dr. Abernathy is a native of Silver Spring, Maryland. He went to college at Morehouse College and graduated with honors in biology. He went on to medical school at the University of Pennsylvania and Hahnemann Medical School, which is now known as Drexel. He later went to do his internal medicine training and gastroenterology and hepatology training at Georgetown Washington Hospital Center program. Dr. Abernathy is in private practice, and he's practicing with the Gastro Health, which has 15 gastroenterologists and 3 nurse practitioners. Dr. Abernathy is also a member of Omega Psi Phi Fraternity Incorporated through the New chapter in Williamsboro, New Jersey. And so I'd like to introduce Dr. Abernathy, and I'll introduce our next guest after he finishes.
Thank you very much. Thank you very much. This is Dr. Abernathy. I'm Dr. Abernathy. I'm a gastroenterologist here practicing in Maryland, a member of Omega Psi Phi Fraternity Incorporated, New chapter. I would like to talk to you as far as about colon cancer and screening. Brother Ford, do you have the slides?
You'll have to reshare them.
I have to reshare them? Oh,
Yes.
okay. Here we go. All right. In the United States, colon cancer is the third most common cancer in both men or women, yet it's one of the most preventable types of cancer. Regular screening for and removal of growths in the colon called polyps reduces the risk of developing colorectal cancer by up to 90% with colonoscopy. What common cancer can you prevent with screening? A, B, or C? Well, the answer is C, colorectal cancer. Colorectal cancer can be prevented, not just detected through a colonoscopy. We do have screening tests for prostate cancer and breast cancer, but that's just for early detection of cancer, not necessarily prevention. You can prevent, not just detect colorectal cancer with the screening test, as I stated before, via a colonoscopy. Removing precancerous growths in the colon called polyps reduces the risk of colorectal cancer. Screening by colonoscopy with removal of these polyps prevents colorectal cancer before it starts. And this is the power of prevention. A real quick anatomy lesson, for those that may not know. The colon and rectum is a portion of your digestive system or your GI tract. So when you eat food goes through your mouth, down to your esophagus, into your stomach. It leaves your stomach, that goes into your small intestines, and then eventually ends up in the ileum and passes into your large intestines. After it passes through your large intestines, it's excreted. According to American College of Gastroenterology, screening by colonoscopy and polyp removal prevents colorectal cancer before it starts. Colorectal cancer usually starts as a benign growth, a polyp, which arises from the innermost layer of the colon called the mucosa. If cells spread into the first layer below the mucosa, which is called the submucosa, then cancer is present. And you can see on my diagram there, where on the left side of the screen, you have a small polyp, and untreated, that polyp can eventually turn into a cancer. So it's our job as gastroenterologists to try to detect these small polyps at an earlier stage so that we can remove them, so that we can prevent the development of colorectal cancer. Some people may ask, what is a polyp? Well, a polyp is a small clump of cells in the lining of the colon. Most polyps tend to be harmless. Some polyps can develop into colorectal cancer. And again, if it's not removed and cancer progresses, it can often be fatal. Not all polyps turn into cancer, but all cancers do start as polyps. Because colon polyps do not usually cause symptoms, it is important to have regular colorectal screening, such as a colonoscopy. And again, remember, screening by colonoscopy with removal of polyps prevents colorectal cancer before it can start. As you can see this diagram here, these are several examples of polyps. Some of them can appear like fungating masses. Some can appear like a lollipop. Some of them are very small and barely visible. So it's very important to undergo a colonoscopy, in addition to other types of colon cancer screening, to prevent colon cancer. Again, seen here, some polyps are very difficult to see. This actually really this is going to be very important when it comes down to performing your bowel preparation for your procedure, because the cleaner your colon is, the easier it is for us to detect colon polyps. If the bowel preparation isn't great, then you can imagine some of these subtle polyps can be missed and patients can still develop colon cancer. So the running theme is always remember that the whole goal is to detect polyps before they have to detect and remove polyps before they have a chance to turn into cancer. Colonoscopy is the only screening test that allows for identification and removal of polyps. Removal of polyps prevents up to about 90% of colorectal cancers, and with appropriate follow-up, the chance of death from colorectal cancer is reduced. This right here is an example of the colon, and what we do as gastroenterologists, we perform a procedure called a colonoscopy. And how does that take place? Well, the day before your procedure, you'll drink this solution that's going to cause diarrhea that tends to flush out your colon. The next day, about 5 hours before your procedure, you drink some more of that solution to flush out your colon some more. And then you come in for your procedure. When you come in, you'll get an IV in your hand. We'll give you some medications to make you sleepy. You'll fall asleep. And while you're asleep, we place this flexible camera inside your colon and we pass it around through all segments of your colon to try to identify and remove polyps. This right here is an example of the several colon polyps that we can find. And the bottom left, you can see the after picture after we remove the polyp. So what are some of these risk factors that we kind of stress for colon cancer? Okay. Some patients can be obese, advanced age, race, but more importantly than that, who's at risk for colon cancer? Colon cancer affects both men and women. There's about 1 in 23 lifetime risk of patients with colon cancer, and as far as men are concerned, and it's about 1 in 25 in women. Estimates show that people born around 1990 have twice the risk of colon cancer and 4 times the risk of rectal cancer than those born around 1950. While the reasons for these trends are complex, experts suggest unhealthy diet and sedentary lifestyle may contribute. Some of those risk factors that I was mentioning earlier, besides obesity, advanced age, African-American race, also include a family history of colorectal cancer, family history of adenomas, cigarette smoking, physical inactivity, those patients who've received radiation to their abdomen or rectum, patients who've had ovarian or uterine cancer, and those patients who have inflammatory bowel disease, and that would include ulcerative colitis and Crohn's colitis. Most early colorectal cancers produce no symptoms, and this is why it's very important for colorectal screening. Never ignore new or worrying symptoms, and you always want to reach out to your healthcare providers if you have any symptoms, regardless of age. What are some of these symptoms that you need to be aware about? Blood in the stool, change in your bowel habits, change in the shape or stool size, rectal pain, abdominal pain, unexpected weight loss, or unexplained or new anemia. So what should I do if I don't have any symptoms of colorectal cancer? Well, as you see, get screened. Screening means getting checked even when you have no symptoms. That's going to be the most important part. There's several screening options for colorectal cancer. The American College of Gastroenterology kind of divides these into one-step screening and two-step screening for colorectal cancer. In many instances, the best screening test is the one that gets done. So if there's barriers that I identify or my colleagues identify, we try to encourage you to get the test that you're actually going to complete. One of the one-step screening tests is probably the most common, is the standard colonoscopy. It's a one-step test that looks for growths called polyps in your entire colon and rectum using a colonoscope. Your physician can detect and remove colon polyps during colonoscopy and prevent colorectal cancer. Colonoscopy is the most commonly performed gastrointestinal procedure in the United States. And colonoscopy with removal of polyps offers long-term protection against the development of colorectal cancer and dying from it. These are some examples of the two-step screening test. These are tests to detect blood or alternate DNA in the stool as the first step. And then usually if one of these tests are positive, that leads to the second step, which would be a colonoscopy for further examination. The first example is a stool fit test. And you probably will hear about this a little bit more later. It's a fecal immunochemical test, and it detects hidden blood in the stool. It's typically performed on an annual basis, and a positive test requires a colonoscopy. The second one is a multi-target stool DNA test. Some people may have heard a stool Cologuard test. There's commercials on TV for this one. It's a non-invasive screening test that looks for abnormal DNA associated with colon cancer or precancerous polyps. It's more sensitive than the FIT test, but as you get older, there's an increased risk of getting a false positive test. As far as the results of this test, if the test is negative, if you're using this as your screening test, you are to repeat this test in 3 years or every 3 years if you're choosing this for your screening test. In the event that your stool Cologuard test is positive, then again, the second step is to go ahead and proceed with the standard colonoscopy. And at this time, the stool Cologuard test is the only FDA approved multi-target stool DNA test. For patients who cannot or will not have a colonoscopy or FIT or not candidates for colonoscopy, some people may pursue a virtual colonoscopy or colon capsule. Again, these are options. I tend to kind of really stick to the first two, but it's important to note that either one of these tests would still require a follow-up colonoscopy if positive. But again, I usually guide my patients to pursue a colonoscopy, a stool FIT test, or a stool Cologuard test. I'm going to skip this slide because we've already discussed a few of these things already. As far as the recommendations for the American College of Gastroenterology, we recommend colorectal cancer screening in average risk individuals between the ages of 45 and 75 to reduce precancerous growths called advanced adenomas, to reduce colorectal cancer, and to reduce death from colorectal cancer. We suggest a decision to continue screening beyond the age of 75 to be personalized. We recommend colonoscopy and FIT as the primary methods for colorectal screening. And we suggest considering the following colorectal screening tests for individuals unable and unwilling to undergo a colonoscopy or FIT test. And that would be the flexible sigmoidoscopy, multi-target stool DNA tests, virtual colonoscopy, or colon capsule. And again, in my practice, I usually don't refer patients for the virtual colonoscopy or the colon capsule. In addition, we recommend the following tests as primary screening methods for patients average risk of colon cancer. You want to get your colonoscopy every 10 years. You want to do your FIT test every year. In regarding to the other test, the stool Cologuard test, you want to do that test every 3 years. There's some other examples there. Flexible sigmoidoscopy every 5 to 10 years is one of the recommendations that you could use. Again, in my practice, I tend not to do a lot of flexible sigmoidoscopies for screening or virtual colonoscopies or colon capsules. Now, one thing that's going to be very important is screening for African Americans. African Americans have been diagnosed with colorectal cancer at a younger age than other ethnic racial groups. African Americans with colorectal cancer have decreased survival compared to other ethnic groups. The ACG guidelines recommend colorectal cancer screening African Americans starting at the age of 45. And overall, within the last year or so, the screening age for everyone has actually been brought down to age 45. So keep that in mind when you talk to your friends, family, and colleagues. For those who have a family history of colorectal cancer or polyps, if you have a family history of colorectal cancer, you may need to talk to your healthcare provider to see if you need to undergo colon cancer screening sooner and undergo a colonoscopy at a sooner date and time. For some individuals, genetic testing may be required to determine your risk for colon cancer. And again, this is going to be dependent on your family history and the age of that person who had colon cancer in your family. And when you don't know, just ask your physicians. That's what we're here for. We're here to answer your questions and concerns, and we can give you the information that you need. So make sure you get your screening test scheduled. How can you arrange your colon cancer screening? You could talk to your primary care physician and tell them that you want to undergo colon cancer screening. More than likely, if you go for your annual physical examination, they should be performing some type of screening in the office or offer you to see a gastroenterologist. Again, gastroenterologists like myself are specialists in diseases of the digestive system, and we actually do perform a colonoscopy, and we also perform other colon cancer screening tests. Here's some information here where you can find a gastroenterologist near you. So please get screened, take care of your health. Talk to a healthcare provider, and don't give any excuses. Here are some of the common excuses that some people may say that you hear, maybe some of your friends or colleagues or coworkers. I feel fine. I'm healthy. Why get screened? No one in my family had colon cancer. I have no risk factors. Only men get colon cancer. So I would like to thank you for attending my lecture and hearing a little bit about colon cancer and screening. And this is my contact information, and also have a colleague in Anne Arundel County and PG County who practices gastroenterology. So you can contact either one of us and we can provide your colon cancer screening needs. Thank you.
Thank you very much, Dr. Abernathy. If you can.
Thank you very much. There you go.
All right. Excellent presentation. We're going to actually go to our next speaker first, and then going to have some questions. Maybe either one of you can answer. But our next speaker is Mr. Kwani Drabo. He's a community organizer for the Colorectal Cancer Alliance, and he's going to talk to us about health inequities as it relates to colon and rectal cancer.
Thank you, Dr. Ford, for the introduction, and welcome everyone. As you mentioned, my name is Kwani Drabo. I'm a community organizer for the Colorectal Cancer Alliance. We are the largest nonprofit organization in the world dedicated to ending colorectal cancer. So the Alliance has a mission, and our mission is to empower our nation of allies who work with us to provide support for their families, caregivers, and survivors, and raise awareness about preventative measures and inspire efforts to fund critical research, all to end colorectal cancer. Some of the facts that the Dr. Abernathy just went over with everyone, I will also reiterate because they are so important that everyone usually needs to hear at least twice or more often than that, just to go ahead and move on this information. And this information is being provided to everyone for folks to move on it, be it informing your loved ones to get screened or to go ahead and schedule your screening for yourself. So, colorectal cancer is the second leading cause of cancer-related deaths in the United States. 1 in 24 people are going to receive or get colorectal cancer within their lifetime. Patients have a 90% chance of surviving colorectal cancer if it's detected early. So when the polyps are precancerous or if you're, being caught at stage 1, you're more likely to have those polyps removed, as previously mentioned, and you'll be able to move forward with your life without having too many adverse complications due to the polyp that is cancerous or precancerous. The Colorectal Cancer Alliance is also very, very focused on addressing health equities, especially as it concerns our community, the Black community. And with that being said, I want to go ahead and just speak to what the Alliance's equity framework is. So we have some desired outcomes, and our desired outcomes are to reduce barriers to equitable screening, care, and research. We are also dedicated to building a nurturing community for people of all races and all backgrounds to feel that they can be trusted and comfortable as they go through their journey. And we're also working on generating evidence on health equity and the best approaches and best practices to communicate with all communities about the impact of colorectal cancer and how we can go ahead and defeat this disease. The way we've gone about getting these things done is to partner with outstanding organizations, make sure that we are double checking our materials to ensure that they're culturally appropriate and supportive to all audiences that they're targeted for. We are also really taking a deep dive into doing more grassroots community engagement. And we're building out a very, very impressive health equity fund, which the Alliance will have a larger announcement about uh, this upcoming month of April for Minority Health Awareness Month. As a focus for 2022, the Alliance is really dedicated to addressing the colorectal cancer disparities within the Black community. And as Dr. Abernathy mentioned earlier, our community is amongst the highest in those who are impacted by colorectal cancer. In comparison to most races, unfortunately, we are 24% more likely amongst our men to be impacted by this disease, and 19% more likely to be impacted by this disease for Black women. And unfortunately, as it concerns death rates in comparison to most other races in the country, our Black men are 47% more likely to perish from this disease, and Black women are 34% more likely to perish from this disease. And it's the third leading cause of cancer-related deaths in both Black men and women in the U.S. Now, even though that news is quite disparaging, there are some very, very important, impactful things the Alliance is doing to reverse those trends and hopefully get that no longer being the data point that we have to reference as it concerns colorectal cancer and its impact on the Black community. And the way we've been doing that is to go ahead and take an innovative approach internally and externally. We've launched a real impressive campaign called They Did Not Say. This campaign led the Alliance to partner with leading cultural influencers to spread the urgent message of early colorectal cancer screening. We worked with outstanding team called Team Epiphany, which is a premier marketing agency, and enlisted some multimedia moguls that some folks may be familiar with, the likes of Charlemagne the God, Mel D. Cole, designer Fashti, and also podcast host Brandon Jinx Jenkins. And they all got involved with the They Did Not Say campaign, and they made some very, very impactful posts on their social media platforms to speak to the dangers of colorectal cancer and how we can work against it. As the doctor previously mentioned, screening is the number one thing that we need to do, and understanding that within the last year, the U.S. Preventative Services Task Force dropped the national recommended screening rate from 50 down to 45. And that means that if you are of even 44, at 44, you should be scheduling your visit to the gastro to go ahead and be screened for colorectal cancer. So besides that outstanding campaign that we've launched recently, we also created a subcommittee within our diversity and inclusion task force that's dedicated to doing Black outreach. And that subcommittee is called the Black Outreach Subcommittee for Screening. It started last summer, and last summer, in commemoration of the first year since Chadwick Boseman's passing, it hosted a panel discussion called Reclaiming My Health, where we had leading advocates and survivors and doctors within the field of colorectal cancer speak to what we can do as a people to prevent this disease, and also how we can navigate the space of being impacted by the disease. And all those panelists who spoke were different Black people who really know their information as it concerns this disease because they're living with it or they're actively fighting against it. And another very impactful thing that the Alliance is doing is partnering with fraternities to raise colorectal cancer awareness amongst their ranks. More specifically, we recently partnered with the Brothers of Omega Psi Phi in the 6th District, and we've targeted that district because unfortunately, within the country, if you're from North and South Carolina, that's where you see early onset colorectal cancer happening at the highest rate. When I say the highest rate, I'm talking something very scary. Nationally, we know that young onset colorectal cancer has been increasing by 2% since the mid 1990s. And in North and South Carolina, the numbers are even more disparaging. So, with that being the case, we partnered with the brothers in the 6th District, and we launched a campaign entitled Screening for Our Legacy. This campaign is intended to disseminate screening fit kits, some of those kits that were just mentioned that can be used as a form of screening to find out what your status is on colorectal cancer. And these screening kits are free. We're just giving them to the brothers, and the brothers are taking the exams themselves and or supplying their community with these fit kits so they can go ahead and take the test and learn about their current status. Outside of providing the resources to learn about your status, we're also providing educational materials and showing up down there to do webinars and also attend conferences and make sure that we're giving very, very personal touch to informing and raising awareness about colorectal cancer. And finally, another important step the Alliance is doing is utilizing our outstanding volunteer base, which we refer to as allies, to get the word out in specific locations that are key to our community, such as DC, the Carolinas, as I just mentioned, Philadelphia, and also Atlanta. And more specifically in Philadelphia, we have a very, very impactful campaign going on where we have paid media, partnership cultivations being done with specific local leaders. And some of those leaders are people from the political realm, from hospitals, think tanks, and also other cancer-focused coalitions. If you're interested in learning more about getting involved with the Colorectal Cancer Alliance, or if you would like to go ahead and make an impact within your community by supplying them with fit kits, please get in touch with me. I will definitely have my information within the Facebook Live chat feature. So therefore, you can go ahead and just contact me directly, or go ahead and visit our webpage or our Facebook page to learn more about getting involved with the Colorectal Cancer Alliance, because we are really trying to reverse the trend as it concerns the negative impact of colorectal cancer on the Black community. And that concludes my speaking portion.
Okay. Excellent presentations, gentlemen. I really appreciate you guys talking. I have just a couple questions, though. First question, Dr. Abernathy. Preparation for colonoscopy. And my patients sometimes, and I've experienced colonoscopies myself. I'm proud to say I've gotten mine. But there's different preps. And I know there used to be that big jug that everyone would have to drink. And right. I think there's some other options now. And I think some of my patients would like to know, what other options are out there.
Yeah, correct. But back maybe about 10 years ago, there was that Go Lightly Bowel Prep, which was a gallon's worth of fluid solution that you had to drink. And I think a lot of us felt like that was a big barrier as far as getting patients screened, because they would just look at that amount and kind of be very discouraged with their prep. So over the years, they've kind of reduced the amount and the volume of the bowel prep. And now everybody's trying to produce low volume bowel prep. So there's one brand called Soup Prep that's available. There's another one called ClinPick. And these are very low volume bowel preparations that allow us to clean the colon in a very effective way, but without kind of causing a lot of discomfort for the patient. Okay. And they also recently come out with some tablets, some oral tablets as well. which we can kind of use, and some very cheap alternatives for those people who may not necessarily be able to afford some of these low volume bowel preps, where we use Miralax and Gatorade over the counter. So those are definitely some options we have for patients. And as long as the patients kind of tell us what their needs are, we can always kind of tailor a bowel prep that works for them.
Okay. And I think that's important because even patients that have had the colonoscopy, say 10 years ago, right? That's when it was still really given those big the go lightly. But now they're just trying to tell patients that, hey, it's a lot more comfortable taking a smaller, more concentrated prep. So that's good information.
Correct.
Second question, we talked about, we know screening as far as the secondary screenings of Cologuard and fit testing. Cologuard, though, are there patients that should not do, say, fit testing or Cologuard? Are there?
Yeah, so usually we try to reserve those tests just for patients who basically just have an average risk for colon cancer. So those patients who either have had colonoscopies before in the past and have had colon polyps, or those patients who have a family history of colon cancer and therefore had an increased risk of colon cancer. Anybody in the increased risk category is not really a candidate for the Cologuard test or the stool fit test. For those patients, we encourage them to go straight for a colonoscopy because that's going to be the right test for them. And then it's also important to note, if you have a patient who has symptoms, it's also standard of care to send that patient for a diagnostic colonoscopy. So for your patients with rectal bleeding, weight loss, change in their bowel habits, a colonoscopy is going to be the best test for them, because we're not really doing it for a screening purpose at that particular point in time. Patients actually having symptoms. Correct.
That's correct. And that's a great point. And that's, a lot of my patients, they'll ask, can I get a Cologuard test? But they've already had a polyp in their colon. So I just wanted to make sure people are aware that that's not the test for everyone. It's a good test,
Correct.
people who are asymptomatic. So I think that was an important point to bring out.
Okay.
The other question I have, we know definitely 45, definitely all African Americans should be screened. I think they say everybody now at 45 should be screened for colorectal cancer, but the cutoff of 75. Okay. And
Yeah.
so that cutoff, you mentioned you should talk to your primary, whether you should be screened, and that is me.
Correct.
And so who are the people that you would say still need to get a colonoscopy beyond 75?
Beyond 75. Okay. Well, I want to just go and stress that most of our society guidelines, whether it be the American College of Gastroenterology, or even American Gastroenterology Association, a lot of us will stop at 75, but there's a lot of gray area and there's a lot of leeway with that age of 75. So what I've kind of do in my particular practice is I will actually go a little bit further than 75. And really what I'm looking for is, does that patient have a high risk, increased risk of colorectal cancer? Are they somebody who has a family history of colon cancer? Have they had precancerous colon polyps? And did they have precancerous colon polyps on the most recent colonoscopy as they approach that age? And then also look at their overall health and their own risk factors. If I have a very healthy 75-year-old and he tells me that his parents lived to 95 or 100, and if that patient has a life expectancy of at least 10 years, then in my mind, I think it's still appropriate to go ahead and screen that patient. So I will continue. As my patients approach the age of 80, I will have a talk with all my 80-year-olds and kind of see what their expectations are with life, and to see whether or not they want to continue with screening or not. Not every 80-year-old is going to require screening. Again, you have a healthy 80-year-old who had precancerous colon polyps 5 years ago, or that 80-year-old who has a significant family history of colon cancer. That might be a patient that you want to go ahead and give them the one last time colonoscopy and take them up to 85 and then stop. But I just had a patient, who had a family member, actually his parents lived to, I think a mother lived to 101, his father lived to 102. He's a healthy 81-year-old guy. My feeling is keep going, right? Keep going until the benefit risk ratio shifts, because in my practice, or just in my practice of medicine overall, we know that if you have a relatively healthy 85-year-old or 88-year-old who presents with colon cancer, it's going to be a very difficult decision with that surgeon whether or not to do surgery or not. So my feeling is if you can kind of take that off the table by preventing colon cancer, then you kind of save that 88-year-old from having to undergo surgery late in their life.
Excellent, excellent. I think we're thinking on the same wavelength.
Correct.
You know, one is making sure, seeing the patient's overall health, right? How healthy they are, and whether they would be willing to go through a procedure, surgery, right? So those are important. But people that are higher risk of family history, significant family history, those people that you definitely would want to consider.
Correct. And I think the hardest discussion sometimes is to have those patients who are very interested in their health, but they have other comorbidity and risk factors that maybe doing a colonoscopy, on them is not the best option. Your patients who've had multiple heart attacks and congestive heart failure, whose life expectancy already is probably 5 years. It may not be worthwhile to do that, but that discussion is hard to have with them. But you kind of have to have it so you put everything in perspective.
Exactly. Make sure they know options.
Correct.
Okay. And we talked about, patients having symptoms of whether they have blood in their stool or weight loss, specifically blood in the stool. And, if the colonoscopy is normal, do you stop there?
For just having blood in their stool, or for
blood in your stool?
Or blood in your stool.
No hemorrhoids, anything like that?
Yeah, it depends on the test. So if a patient comes in and has gross blood in their stool and their colonoscopy is normal, then I usually would probably stop there. If their complaint was actually bright red blood in their stool.
Right.
Because most times you can kind of determine that. Now, where it's a little bit more complicated is if you have a patient who comes with microscopic amounts of blood in their stool from a stool test and the colonoscopy is normal, then the question is, could they be bleeding elsewhere in their GI tract? And I believe most of us would still look elsewhere just to make sure there's nothing else going on. So we would probably go ahead and pursue an upper endoscopy and probably a small bowel capsule endoscopy to look at the upper GI tract and the small intestines to make sure everything's okay.
Very good, very good. So, gentlemen, I think the big take-home point for this webinar, when you said that colorectal cancer is preventable versus most other cancers, you catch it at an early stage.
Correct.
And so if everyone understands that, that's a big thing. You can prevent colon cancer by coming in, getting screened early, and keeping up with all your screenings, making sure you're talking with your physician about your screening tests. And so also just wanted to say with Mr. Drebo that, hopefully, the Gamma Pi chapter can also work with you in getting the word out as far as screening for colorectal cancer. I think you're doing important work in doing that.
I have a question, if you wouldn't mind.
Sure.
I just want to know, as it concerns individuals who are under the age of 45, who are experiencing symptoms, how likely is it that they can get screened, and how would they go about engaging with their primary care physician and also a gastro to go ahead and let them know that hey, I think I need to get checked out?
Yeah, that's a very important question and point to bring up, because we actually see a lot of patients, ranging from 18 all the way up to 45 who do have some problems like rectal bleeding, abdominal pain, weight loss, and things of that nature. And I think for them, it's just going to be very important for those age groups, 45 and under, to kind of look at it as we're doing an investigation to look into their symptoms. And what they need to do is bring those symptoms to their primary care physician's desk or to my desk so we can kind of have them addressed. Because, you know, a 30-year-old, for example, patient with rectal bleeding, more than likely it's hemorrhoids, more than likely. You know, you don't want to wish colon cancer on a 30-year-old, but the reality of it is 30-year-olds can present with colon cancer. You know, Chadwick Boseman was under the age of 45 when he presented with colon cancer. Screening wouldn't have caught Chadwick Boseman. It would have been symptoms that would have kind of alerted somebody to investigate those symptoms at an earlier stage. So if he presented with rectal bleeding, then instead of maybe saying, oh, it's just due to hemorrhoids and blowing it off, maybe if he saw a gastroenterologist earlier, they would have looked and maybe found something earlier. But again, even at that point in time, he could have had cancer when he first presented. So the main thing is going to be, if you have symptoms, you know, talk it over with your primary care provider. You can talk it over with your gastroenterologist, and then they can kind of determine how much of an investigation that they need to do to kind of to make sure that you're safe. And again, you know, we do have some guidelines that kind of give us a guide as far as what to do depending on the age group. I've been in practice for a number of years, and I kind of have in my head as far as how aggressive I want to be depending on the age of the patient. And I will kind of take that into account. And as patients, you know, get out of that 20s and start approaching 30s and 40s, I tend to be pretty aggressive. You know, and you also, as a gastroenterologist, just have to realize that, hey, if hemorrhoids and they continue to bleed doesn't make sense, hey, maybe that patient should undergo a flexible sigmoidoscopy. You know, it's not invasive as a colonoscopy, but it can catch a lot of cancers at a, you know, catch a lot of cancers, period, you know, in that age group.
I also, sorry. I would just want to put one more thing out there. I asked that question also because right now I'm 38, and last summer I just had a colonoscopy. And the work I've heard some of the young people that they've had to go through to get colonoscopy has been excruciating. And those individuals had maybe their doctor listened or understood or thought that maybe this could be more than just you know, something that's not colorectal cancer. They could have been caught earlier, and that young onset population, that 2% increase since the 1990s, that thing right there is like starting to become a larger base of the Colorectal Cancer Alliance, and we're like, oh my God, you know, is this landscape of colorectal cancer changing that much?
Yeah, no, I mean, I think that's a very important point. I mean, I think in my experience, I think there are some disparities that are out there, even from, you know, some referring physicians as far as when to pull that trigger to send somebody on for further workup and evaluation. And we do know that there's some, you know, health disparities amongst African Americans. You know, you can maybe present to a certain physician and you have the same complaint of abdominal pain or rectal bleeding, and because of maybe your race, you know, you're kind of shoved off as just being hemorrhoids in one category, and somebody else may be forwarded on to a gastroenterologist, or somebody may take you a little bit more seriously, you know, a certain patient more seriously and be a little bit more aggressive in the workup. Then you take the same symptoms in somebody else and you're not really that aggressive. So there are some disparities there, and I see it even in some of the referrals that I've received, as far as patients, you know, being an advocate for themselves and, you know, getting to my standpoint or getting in front of me, that maybe the primary care provider didn't necessarily refer them on. And I think educating primary care providers and other patients that, hey, if you have alarm symptoms like the rectal bleeding, unexplained diarrhea, weight loss, change in your bowel habits, by all means, bring it up to somebody so somebody can make a determination of how aggressive, you know, we need to be with their care.
Thank you.
And I think there's a big distinction too with having symptoms.
Correct.
Right. And we're talking about screening.
Correct.
When you're screening, people don't have any symptoms. Right. You don't have symptoms. It's
Correct.
just a normal time that you go in to get your colonoscopy. As far as people that have symptoms, if you're having any of those, you know, blood in the stool, weight loss, abdominal pain, then that's a workup that needs to be done, whether colonoscopy, whether they need any other testing done, but that's based off all the symptoms and what the physician is seeing. So screening versus having symptoms are two separate things. And so I think hopefully we can distinguish those two.
Correct.
Okay. Well, gentlemen, I think our time has come. I appreciate all your knowledge that you imparted on the group today. And I think hopefully we'll have a long partnership with all of us. All right.
Thank you.
Thank you for having me. I appreciate it.
All right. You guys take care.
All right, you too.
Thank you.
All right.